Melanoma Matters is an educational resource. The content represents our opinions and does not constitute medical advice. If you're a patient with questions specific to your situation, please consult your medical practitioner.
Hi, everyone. Welcome to Melanoma Matters. I'm Sapna Patel.
And I'm James Larkin. Hi.
So you're doing it again. You're coming in like a whisper. What is that?
No.
Use your
I need
podium.
to increase my volume, do I?
Yeah.
No?
Or,
Okay.
yeah, you're coming in with like operator voice first. This is my 1-800 voice first.
Yeah, okay. Need to fix that.
Okay. Well, we're keeping it all in because that's fun, as you say. Well, we were going to talk about CheckMate 511 because this is a widely cited study in the melanoma space. In many instances, it's used as justification for why an inverted dose may be considered a dose du jour. So before we get into CheckMate 511, maybe we'll do a quick fire. I wanted to ask you about your number. What's your number? And before I'd asked you about number of countries you've visited, and we both agreed that's just not something we track. What about, do you have a sense of your frequent flyer miles? How many miles you've flown?
No, but this would be embarrassing anyway, wouldn't it? If you see what I mean, like all that planetary destruction.
Greta Thunberg would be after you.
Yeah. No, not really. Before COVID happened, I guess I was sort of keeping an eye on it, but I haven't really kind of bothered since COVID, to be honest with you. But nowhere near enough to get the permanent British Airways card, if you see what I mean. So there's a level at which you can then just get a permanent card, and I'm not close to that. But, you know, I think you need to be doing long haul, I don't know, at least once a month, basically. So the people who are really, you know, needing to do long haul that much, they'll get them. But I'm not even close to that, basically. So yeah, sorry.
It feels like you're not a status junkie, which is a nice thing. That's a good thing.
Yeah, I mean, that'd be a weird thing to, you know,
get status highs over.
Yeah, or compare notes on even, you know, how many miles have you got?
You've seen that George Clooney movie, right? Up in the Air.
Sorry?
Did you see that George Clooney movie, Up in the Air?
No. Does it happen in that?
Yeah, that's exactly what it is. It's two people who start dating and meeting by comparing status in the airline lounges, and then they throw down their, you know, Marriott cards and then their Hyatt cards and then they start comparing their schedule. Where will you be here and there? When should we meet up? And when will our million miles cross? You know, so we can.
Is it good? It doesn't sound good.
It's actually very charming.
Seriously,
very charming. Partly because of what his job is in that movie that causes him to accumulate all these miles. I won't spoil it for you.
Oh, really? Okay.
And then the director is, I think it's Jason Reitman, if I'm not mistaken. And he's like Ivan Reitman's son, I think. I hope I'm not getting that wrong. Well, something to fact check, I guess. Ivan Reitman did Twins back in the 1980s. Do you remember that movie? Might have been the 90s.
I'm too young, I think, for that. And presumably
Arnold Schwarzenegger and Danny DeVito. The whole movie.
Yeah. No. So yeah, but I'm not sure I've seen it. And presumably he's a hit. Presumably George Clooney is a hitman. Then is that the answer to his profession? Oh, okay. That would have been my first guess.
No, he's a businessman. Yeah. Anyway, I think Ivan Reitman also did Ghostbusters. So his son then did this one, and it's very charming.
Okay, I'll write it on the list.
Okay. Okay. So CheckMate 511. CheckMate 511 is a comparison of two dosing regimens of Ipi/Nivo. It's what we often refer to as standard dose or full dose versus flipped dosing. So maybe you can just take us through those regimens. And, you know, it had an interesting primary endpoint, but I think gets interpreted often as it's comparing the efficacy of two dosing regimens. But maybe you can set us straight on CheckMate 511 and maybe even why it was done in the first place.
Yeah, okay. So the manuscript is JCO 2019. First author Celeste Leve, and Jacopo Pigozzo is the senior author. And just to sort of address one question first of all, so this is called a phase 3B/4 trial. And in the purpose, and look at the abstract now, the purpose was to determine if Nivo 3 plus IPI1 improves the safety profile of the combination. I read that all word for word, okay? So, I mean, I can tell you for free that, and I think most people could, that doing an alternative dosing regimen with less IPI will cause less side effects. The only actual question, to be honest, is what is the level of side effects, not whether there'd be less. So I honestly don't really know why the study was done for the reasons that I've just alluded to. Anyway, just to move on, 360 patients, randomized trial, so smallish randomized trial. Standard inclusion criteria, I think, metastatic melanoma, one-to-one randomization. So you could have Nivo 3 IPI1 or the, if you like, standard or traditional Nivo 1 IPI3, and then you had the induction doses, and then you could then get on to maintenance nivolumab. And the kind of critical point, I suppose, as you said, is the primary endpoint of the trial, which was the incidence of treatment-related grade 3 to 5 AEs between the two groups. And then other endpoints, secondary endpoints, descriptive analysis of response rate, PFS, OS, and it was not designed, and again, I'm reading this from the abstract, to formally demonstrate non-inferiority of the lower dose IPI regimen. So that's the, I guess, I think in many ways, those are perhaps the most important overall points. So lo and behold, and this was after a minimum follow-up of 12 months, the incidence of grade 3 to 5 AEs was 34% with Nivo 3 IPI1 versus 48% with Nivo 1 IPI3. And the P number there was 0.06, i.e. statistically significant. I think now is when we start getting into the kind of murky, confusing stuff, which I'm sure are the main points really for discussion here, honestly. But again, I'll read it out because I think it's important. In descriptive analyses, objective response rate was 45.6% in Nivo 3 IPI1 and 50.6% in Nivo 1 IPI3. CR rate was also quoted was 15% versus 13.5%, bearing in mind this is a relatively early follow-up point. And the PFS, they've listed the medians 9.9 for Nivo 3 IPI1, 8.9 for Nivo 1 IPI3. Median OS not reached at the time of this analysis. So perhaps before we start talking, I'll just read out the author's conclusion, which is the study met its primary endpoint, demonstrating a significantly lower incidence of treatment-related AEs, grade 3 to 5. And then the other sentence is that descriptive analyses showed no meaningful differences between the groups for any efficacy endpoint, although longer follow-up may help to better characterize efficacy outcomes. So there we are. That's the JCO paper. And maybe before we talk, there was some follow-up, I think, but I might be wrong about this. All I'm aware of is the 3-year results which are presented at ASCO 21. I'm not aware that there's a manuscript that's been published, which in itself I think raises a couple of questions. So I'll shut up for a bit.
Well, no, I mean, maybe you can tell us if that 3-year follow-up, did it change anything? Was there any further difference in toxicity or PFS OS?
Yeah, okay. So again, looking at this ASCO abstract, so now there's about 44 months median follow-up in both arms, and the rates of grade 3 to 5 treatment-related AEs are now 34 versus 48%, which is about the same. There's a statistic here, odds ratio 0.55, confidence interval 0.36 to 0.84. There's some description of what the toxicities were, none of which I think would come at any kind of surprise. And the OS and treatment-free outcomes were pretty similar between the two groups, and both groups had a sort of relatively high 3-year OS rate. I'm just looking at the table now, which is kind of around about 60% in both arms, give or take. So, I mean, honestly, I think that analysis kind of confirmed the earlier one and has given you some figures for sort of landmark OS. I'm not sure you can take it too much further than that, actually.
Any hypothesis of why we didn't see a publication from this?
No, but I think it would have been nice to see a publication. It'd be the first obvious comment, because I mean, it's fine presenting at meetings, but at the end of the day, it's good to have a manuscript with more information and peer review. So I don't know why. And I think my other kind of broader comment on this would be that, we know that this has actually had quite a lot of uptake, this new treatment regimen. And I think we now know that metastatic melanoma is a potentially curable disease. So therefore the later landmark OS is important, I would say. And, I wasn't involved with this study, but from my own personal perspective, it's a shame that we don't have manuscripts and actually follow up beyond 3 years, I think, because I know it does require resources to analyze at a later time point. But if you think about the cost of setting up the trial in the first place, actually, is it really going to be a big increment in terms of resources? So I think that's a bit of a shame.
I'm only laughing because nobody loves a CheckMate follow-up more than James Larkin in a CheckMate 06 study.
Oh, that hurt.
I say that with love. I mean, your point is very well taken for all the follow-ups we've seen there. And you're right, for the cost it was to set up this phase 3B4, you provided drug at these different dosing regimens. You then went so far as to comb the data for 3-year follow-up. Go give us some stringent, maybe show us some subgroups here, show us something,
Yeah. Yeah, and that's the big question, actually. I mean, if we just take a slight step back, we knew that there'd be less tox. It's given us a number, okay? But the big question in everyone's mind is obviously, how does the efficacy pan out? And I think that in the field, as it were, we're looking to see how it pans out at later time points. It's obviously critically important. And if you truly could give less IPI and have less side effects and maintain your efficacy at these later time points, that's really important information. But I will just say there as well, the whole thing about epidose, we talked about it exhaustively before, but it's an important point. We know that more IPI equals more efficacy, certainly as a single agent. And so that's one of the things that's made me a little bit conservative about this whole thing, honestly, in those later time points. Plus the slight concerns, again, which we've talked about before, about brain mets, actually, and on what's happening at those later time points.
So you bring up a good point. Later time points, you have less patients, and to be clear, they're analyzing for something they weren't powered to do. So what type of statistical error is that? We teach our fellows this all the time, right? When you have too small a sample size, do you remember what type of? I think that's a type 1 error, right?
It's either a type 1 or a type 2.
Good.
There is no type 3.
But I think with a small sample size, you will have a hard time telling two groups apart. You have a group of different colored marbles. And if the sample size is too small, they will maybe look similar with too small a sample size. And so we call that a type 1 error. We should probably fact check what a type 2 error. It's the error of accepting the alternate hypothesis when there actually was no difference, I think.
Incorrectly. Yeah, I think that's right.
Yeah.
But now we have to fact check.
Yeah, well, good. Now we have something to actually fact check. I had good examples I can think about. Maybe we can put in the fact check, like real world examples of how to think about that. So then I guess the bottom line is you've told people, look, there's a tox difference, but you're cautious about this and the kind of interpretation because of that lower IPI dose. We don't have a clear sense, right? Do we have it from the original paper? A clear sense of the demographics? Do they have brain mets? Do they have high LDH patients? Do we know anything like that? BRAF mutation?
Yeah, I would need to go back to the original paper and check all of that. And I can't believe that wasn't in the original paper in the JCO in terms of baseline characteristics. But from my memory, I think it was a reasonable group of patients at baseline for metastatic melanoma. I don't think there's any concerns there. I think brain mets would have been an exclusion. So, I don't think there'd have been any concerns there. But my concern is about later development of brain mets, as we've discussed before, as a dominant or sole site of progression. And I think that is potentially important with that question.
So around the world, how does this play? I mean, in the US, it plays. I can tell you about that. But around the world, how does this play?
I think around the world, I don't think there's that many places where people are able to do this, because most people are constrained in terms of reimbursement with the label. And to my knowledge, this isn't in the label. So therefore, people, at least from an official perspective, if you want to say that, if you're going for Ipi-Nivo, it's with the, what you might call the classical dose of Ipi, shall we say. And there isn't really any flexibility to do otherwise. I think that applies to most places. But I know in the US, because Jeff Weber always used to talk about it a lot, apart from everything else, this does get quite a lot of play. At least that's been my impression. And then I think to myself, and I'm sure we've discussed this before, if you've got this type of regimen with less tox than classical Ipi-Nivo, how does that then compare with Nivo-Rela? That's a question in my mind, because we know there we've got some more efficacy and a bit more toxicity in comparison with single agent anti-PD-1. I mean, it's never going to happen, but in my head, I wonder how this type of regimen would stack up against Nivo-Rela.
So I'm still back to maybe my first question. Why did they do this study? Because I just counted out 18 authors, 17 of whom are ex-US. There's only one US author on this paper. So their push was not really, was it to get the rest of the world to do this study so that the US would adopt it? I mean, if they did, bravo, that happened without a label change. But I still am unclear, why do a phase 3-4 if you weren't going to go get some label change around the world? But nevertheless, in the US, this has really swayed practice. I've seen people certainly feel comfortable that the benefit is the same in these two regimens. And I, like you, retain quite a bit of caution and just feel that 3-year follow-up is, not long enough for me. It's very reassuring for me to see something like 067, as much as I give you teasing about it, to see long-term follow-up showing clear maintenance of separation of curves and, benefit, and where that starts to plateau. I'm not sure I know that yet with the inverted regimen. But what has happened in the US because of this toxicity issue, and I understand it makes a lot of sense, is that if toxicity is your concern because a high rate of toxicity means more support for your patients, means more subspecialty care, hospitalizations, et cetera, and you work in a fragmented network where you don't catch all of those under one roof, or it's harder for you to coordinate with these practices to help evaluate your patients for toxicity, then a lower rate of toxicity with an OS that looks numerically similar feels reassuring for you. And so we trained up many a fellow with the classic dose of Ipi-Nivo, the OG dose, where they go out into practice and they end up using the inverted, and we'll come back and say, I wonder why this group is using, but then you ask them about their connection to these toxicity subspecialists, and it's harder. And then I think that's the answer. So I think that's how it's been implemented in the US, but there are certain subgroups I think we do not like lowering the dose. And we see it still in practice, and it gives us a little bit of heartache when a patient has brain mets. We have no data about low dose Ipi in the brain. You know, we have data about full dose Ipi in the brain it's good and still not enough. So we wouldn't want to compromise that dose. The mucosal patients, I think we're not sure what to do. You know, do they need the Ipi at all based on certain studies maybe we'll talk about in a future episode? And then what dose of Ipi? Is this another group of patients where more is more? I mean, more is more in all melanoma patients with Ipi. I don't know. You know, the one place where we clearly think this regimen looks good is in the neoadjuvant space. They looked in OPAS and NEO at these kind of the optimal dosing regimens and found that this inverted dose looked to be just as efficacious for path responses with much lower toxicity. But beyond that, I find myself also just sort of being a purist with the classic dose.
Yeah, I mean, a couple of comments. I mean, you know, you talked about neoadjuvant there. Well, you know, Christian Lanka and colleagues actually really went about asking this question, you know, in their earlier studies. So that I think the point is that, you know, there are data in that situation. And then the other question for the benefit of anyone who might be listening is OG, Original Gangster. Is that what OG stands for?
Yeah, you knew.
Well, did I?
Yeah,
Just
you did.
Check that wasn't some sort of, you know, complex acronym or anything else. I can use that now when I'm doing a talk. I can talk about the Original Gangster dosing.
You can. That's you, James Larkin, OG. That's how I refer to you.
S. Patel, personal communication.
The O is OL, you know, like, or wait, I didn't say that right. Original. ORL. Anyway. Yeah. So.
Good.
Okay.
Glad we cleared that one up. Sorry.
Yes. Anything left to say about CheckMate 511, you think?
No, not really. I don't really understand, as we've said, why the study was done in the first place. But to me, it just feels like a shame we haven't seen more follow-up from the study, and we didn't see a manuscript, at least not that I'm aware of, at the 3-year mark. But I guess it's kind of done now. We've moved on. You know, Nivo-Rela's out there, and maybe this dosing regimen's really going to find its place, as you've said, in neoadjuvant. So that's great.
Yeah. Yeah. I mean, congrats to these authors. We're glad, you know, they looked at this toxicity. You called it free science or something that lower dose Ipi. I call it SOTO, science of the obvious. But at least, you know, we have it here. So, okay, let's make a fact check on this one, shall we?
Yeah.
Okay. All right, that one. Okay, now we're going to fact check this episode of CheckMate 511 because we're not so smooth in this one. I think first thing, James, we were looking at if there were different subgroups described in the demographics table.
Yeah, and I'm just looking at table 1 now from the JCO publication. Actually don't think there's much to say, and I sort of got it right almost by chance anyway, but I think these are all reasonable baseline characteristics. Maybe pick out a couple of things. LDH greater than upper limit of normal is about 40%, putting the arms together. A bit of a difference actually between the two arms, but that kind of ballpark. Greater than twice the upper limit of normal, around about 10%. Again, putting the two arms together, but a bit of difference between the two arms. Brain met's only 2% in both arms, so pretty small. And BRAF mutants about 40% in both arms. A little bit of prior adjuvant treatment, but only sort of 10% or so. So I think that's a kind of reasonable set of baseline characteristics for a metastatic melanoma trial. And it doesn't sort of make me think, at least, oh, this is some crazy group of patients, but not really any comments on anything beyond that.
What I would have liked to have seen based on what you just described then is probably a comparison of the two regimens in the BRAF mutant population, because in that most recent indirect treatment comparison paper of RELA 047 versus CheckMate 067, this is something where it seems like the BRAF mutated patients are doing well with full dose Nivo-Ipi, or trending towards better, with full dose Ipi-Nivo. So would the dose of Ipi have mattered here? I would have liked to have seen that with CheckMate 511. It's not too late maybe for them to at least do this and show it to us, but I don't think it's going to get a standalone publication at this point. Okay, and then we talked about type 1, type 2 errors. And I was wondering which error is related to sample size. I think we went through this a little bit, that I think we believe, and certainly we could be wrong because we are not statisticians, but that a type 2 error is related to sample size. And so just sort of high level things here. Type 1 error is related to the alpha of a study. And it's the chance of essentially calling a difference between two groups when there is not one. So if we arbitrarily set this alpha of 5% or 0.05 and the p-value falls below that, we could be making a type 1 error if really there is no difference between these two groups. That's not necessarily related to sample size. That's just where we set our alpha. And so if you set your alpha at, and maybe if I'm being reflective about S1801, this is part of the FDA's issue with it, our alpha was 0.15. And so we came out with an alpha or a p-value of p0004 in that study, a two-sided p-value, or 004. Let me not overstate it. So the issue is, based on that p-value, we're well below the alpha by which we said there's a difference in these two groups. Therefore, we are saying there is a difference. If your alpha is too liberal like that, maybe you run the risk of calling a difference between two groups when there isn't an inherent one. That would have been the case if our p-value was, 0.14 with an alpha of 0.15, but our p-value is so significant. So anyway, I still don't really understand why that was called like I can't remember, random high event is what they called that outcome for S1801. So back to it, type 1 error related to the alpha of your study, and it's related to calling a difference between two groups when there isn't actually one. A type 2 error is the opposite. It's the failure to detect a true difference when there is a difference between your two groups, and that is related to sample size. So CheckMate 511 runs the risk of a type 2 error. The sample size of 300 some patients. It's the failure to detect a true difference in PFS and OS in this group when there is one, because the numbers are too small. So I think that's probably all I should say about type 1 and type 2. Yeah?
Yeah, great.
Okay.
Thank you.
Then in case anybody cared and was listening to our intro, we talked about Up in the Air, which is that George Clooney movie, 2009. It was Ivan Reitman's son, Jason Reitman, as the director. That might have been all we needed to fact check about that. So,
right. And so, my take home is that it's quite complicated to remember the difference between type 1 and type 2 errors. So you probably need some sort of system to do that, something memorable that you can carry on in your head. So maybe Sapna, not now, but like in a subsequent podcast, you can share your system.
Sure, I need to revise mine. Okay, that's all. See you later, James.
All right.
Fact check. Yeah, it's a fact check. So
Okay, so this is a fact check of a fact check for CheckMate 511. Because what we said before about subgroups, especially BRAF mutant melanoma, there isn't actually much in the paper. But if we look at the supplement, this is figure A3 I'm looking at now, a comparison of response rate between BRAF mutant, BRAF wild type for Nivo 3 IPI1 versus Nivo 1 IPI3, taking into account it's a small trial and so on and so forth. But if you look at those bars and you look at those response rates, I really don't think there's much to choose that's in there at all. So we just wanted to include that for completeness, and apologies that it's a fact check of a fact check.
Great.
And now I can close that window.